a lot of participants. And we will repeat this course next year. If you are interested in doing it, in practicing in models and in cadaver lab, you can contact me for this. Well, let's start. First of all, we have to understand, I think you know, I think that in India is the same in the rest of the world, that the fact is the thyroid's ultrasound prescriptions are rising through the years. We can see here in this graphic the geometrical increasing on requestings of ultrasound in the United States, for example, 20% a year increasing rate. And this examination, for example, here in Brazil, in the late 80s, the cost of an ultrasound exam is the same cost nowadays of a magnetic resonance. It was expensive and not very available. But nowadays, everywhere there is an ultrasound device, and every clinician, gynecologist, general practitioner are asking ultrasounds for their patients. And then, as we can depend of this, with a lack of accurate indications, and then we have a lot of diagnostics of thyroid nodules. Well, as this Italian study shows us, most of the thyroid nodules, benign thyroid nodules, remain stable during the time. About 75% of the thyroid nodules will remain stable. A proportion of them will shrink, and about 11% of these nodules will grow with the time. If you extrapolate these numbers for the number of estimated nodules in the population, you have a lot of thyroid nodules being discovered that will grow with the time. And then we have this problem, what to do with these nodules. Traditionally, surgery was indicated or is indicated for these nodules when they have static or functional symptoms for the patients, like difficulties in breathing or in swallowing. And we need to operate these patients, even with total thyroidectomies or partial thyroidectomies, but a significant percentage of these patients will develop some grade of complications and some grade of hypothyroidism with the time. Well, the technique of ablation of any kind of tissue is not new. In this timeline, we can see in the middle 1800s, some cases reported of advanced breast and uterine carcinomas were treated with acid saline solutions. The ultrasound, the first uses for medical purpose, reported from the late 1900s. And then with the passing of time, many kinds of techniques that we can call ablation or thermal ablations were developed, culminating in the 90s with the first use of percutaneous radiofrequency ablation for liver tumors and metastasis in liver from the other organs. Then the technique is not new. About 20 years ago, this technique is used for larger organs like lungs, like liver, like kidneys, or even bone, was adapted to be used in thyroid tumors and other structures in the neck. What's the basic principle of this? Is to let coagulation necrosis, the histological appearance of the tissue after the thermal ablation is of the coagulation necrosis that occurs with temperatures over 50 degrees. More recent studies show us that with more than 60 degrees Celsius, we can achieve the coagulation necrosis of the tissue, but we have sublethal damage area with lower temperatures that can bring us some problems, as we will see during the presentation. Well, if you go to the PubMed, for example, as a source of information and put only these single terms of search, thyroid thermal ablation, we can see an increasing in publications about this subject in the last years. Then it calls our attention the number of papers and the number of publications dedicated for this subject in the last 10, 15 years. But we have a lot of tools to call ablation tools. We have the electromagnetic tools that include the radio frequency, microwave, the laser, and the electroporation. We have the mechanical tools, the high intensity of acoustic ultrasound. I've never seen this, it's very rare. Some places in China, some places in Europe, and a few ones in the United States are using this tool, but I have no knowledge about this, how it functions exactly. The cryoablation is another kind of thermal action. And the injection of ethanol, for example, or other chemicals, or even the chemoembolization through arteries are tools of ablation of tissue. The thermal ablation, leads to cellular injury beginning at 45 degrees centigrade. When we achieve 46 degrees, you have an irreversible injury in about 1 hour. If you increase the temperature only in 4 degrees, you have the same injury in about 4 or 6 minutes. But if you have 60 degrees Celsius, you have instant irreversible injury. Then the target to be achieved in the tissue you need to ablate is 60 degrees Celsius. And over 100 degrees, we have vaporization and carbonization that we do not desire for our patients. That was the problem with the initial casuistics in the early 90s with the laser, for example, excessive carbonization and not so effective ablation of the tissues. We have some concepts in the thermodynamics that we can observe in these techniques, especially here in our subject of conversation that is microwave ablation. We have a direct heating zone all over the active point, the active tip. It's the energy deposition zone, it's the fast heating, it's the engine that leads the coagulation necrosis of the tissues. It's where the maximum temperatures are achieved. We have a second zone, the mixed heating zone. It's a hybrid zone between the direct and the indirect heating transmission. And the third one, the indirect heating zone. That means there is a passive heating due to thermal conduction with slow propagation, more suitable for heat sink or heat loss effect. It becomes more relevant according to the distance of the tip of the antenna, for example. About the direct heating or the active ablation zone. It's the damage provoked there directed by the instrument. It's the only one physical component in an ablation that makes a difference. The direct heating zone or the active heating zone is the one that will gives us the objective results of the ablation. Is the fast engine of thermal ablation and are composed by two elements, the energy absorption rate, SAR, and the penetration depth. Well, the diffusion or indirect heating zone is where the heat diffuses from hot to cold zones. It's a more slow heating mechanism, and the diffusion rate is proportional to the difference of temperatures between the zones. And the techniques, for example, laser, microwave, radio frequency, differ only in the ability to generate adequate gradients of temperature between the zones. Well, among all the thermal ablation techniques, currently, the electromagnetic heat sources are the best options to be applied for tumors in medical practice. Why? Because it leads a control induced of necrosis. They are safety and easy to use, and they have a very good cost-benefit ratio. Here we have a graphic showing the electromagnetic spectrum, the kinds of energies that are involved in this kind of procedures. And for us, we need to know the difference between the three most important: the radio frequency current responses, that is due by the excitation of the movements of the ions between the electrodes, and the heat is proportional to the density of the current. The main concept is the current passes through the body of the patient. However, the response to microwaves is the excitement of dipole rotations of water molecules. The direct heat is proportional to the density of the electric field, and the patient was not submitted to a current, electric current, passing through his body. That's one of the advantages of this technique. And the last one, the laser response, is the excitation of intermolecular vibrations, and the direct heat is proportional to photon density. Well, here we have to know about two concepts: the water energy absorption rate of the tissue you are submitting to the thermal ablation. For the frequency below the visible light, the energy absorption rate increases with the frequency. Where you can see here, the lowest frequency of these three techniques is the radio frequency. Microwave is much more frequency than radio frequency, and the laser is the highest one. But if you go to the concept of depth of penetration, that is the distance reached by the electromagnetic field from the source, from the tip of the antenna of the electrode of the laser fiber, for example, it determines the direct or the active heating zone. That's the most efficient, the most important zone of heating. And it's inversely proportional to the frequency. Then, the higher the energy absorption rate, the lower the penetration depth. Then we can see this here. The depth of penetration for laser is a few millimeters, because and the energy absorption rate is very, very good. It's excellent. It's a few centimeters for microwave, because microwave has a very good energy absorption rate. And for several centimeters for radio frequency ablation, because radio frequency have a relatively weak energy absorption rate comparing with laser and microwave. Then we can conclude what? That laser is exceptional thermal performance for close range. In other words, laser can be used for small tumors, for microcarcinomas, for small metastases with millimeters, not centimeters. Then, Then the clinical challenges are the difference between radio frequency and the microwave. These are the most used tools for our area, that is thyroid. Let's know about the device. This is the generator of echo microwave. It's a cyber wave. It has a solid generator here inside to generate the electric field in the microwaves, an integrated cooling pump to cool the tip of the antenna, and an interactive touch screen interface that shows us the power that you are delivering during the procedure, and the time and how many cycles you use it, and the time of each cycle, and the temperature in the tip of the antenna. These are the informations we can you can see during the procedure. This one and this one are one of the most important, because the progression of the thermal ablation with microwave, you can see with the effects on the ultrasound screen, the hyperechogenicity, and the relation between the power that you are delivering and the time this power are delivering in a specific zone of the tissue you need to ablate. These are the antennas. We have two sizes, 17 gauge and 16 gauge, available here in Brazil, with an active point of 3.5 millimeters. And the length of this antenna is 10 centimeters. It's a little bit longer than radio frequency electrodes. Why it's important to know energy is much more higher in the 16G antenna. As you can see in this table, if you deliver 30 watts during 20 seconds, you have this length of ablation and this diameter of ablation zone. If you leave 10 more seconds, it will increasing progressively according to the time you leave the tip of the antenna in the portion of the tissue and the power you deliver to the tissue. And then the longer the time you leave this antenna, pushing slowly through the tissue, you achieve more and more greater ablation zones. It's the same for the 17 antenna with less potency and less ablation. Then you can choose the 17 antennas for smaller tumors and the 16 antenna for the larger tumors. Well, what are the benefits of this technique in thyroid nodules? First, it can be done with local anesthesia and myosedation. Here in our service, we use myosedation in all cases, but we have some colleagues, for example, Dr. Bülent from Turkey. He does not use any kind of sedation, only local anesthesia. It's a choice of the physician and according to the profile of the patient. It's a day hospital procedure. The patient can be discharged 2 hours of the procedure. The results are similar to the traditional treatment that is thyroidectomy, with a low rate of complications, no scar, and the most important one, preserves thyroid function. We do not have hypothyroidism in cases that you apply the correct technique of ablation with microwave devices. And what are the indications? First, for benign disease. Benign nodules, the volume was a concern some years ago. Some articles said that nodules with more than 20 milliliters could not be ablated with a single session. It's not true nowadays. We can ablate larger nodules, as we can see later. And the morphologic characteristics of the nodule are important. If the nodule is more solid, more cystic or mixed or spongiform, and the position characteristics of the nodules. Because nodules that are too close to important structures, as you can see later in the technique, such as the trachea, such as the esophagus, the laryngeal recurrent nerve, carotid artery, vagus nerve, you can perform, but you need to take some precautions. For the autonomous thyroid nodules, until 5 years ago, the studies show us that better results are achieved with nodules until 12 milliliters. Nowadays, we can have good results, even better than radioiodine for these cases, with larger nodules, but we can evaluate the patient very carefully. And for malignant disease, we have the indication for malignant nodes, basically the thyroid papillary microcarcinoma, less than 1 centimeter, and lymph node metastases that are single, visible, totally visible with ultrasound, and with known structure invasion. If the lymph node metastases are invading some structure, are attached to the jugular vein, for example, or for the tracheal wall, it's not a very good indication. But we show you how to perform this. But, and there is always a but, we have some considerations. The nodules, benign nodules, mainly the bigger nodules, are reduced, but not totally eliminated. You cannot have total elimination of the nodule unless this nodule is a little one. And you have the potential regrowth and the need for additional treatment, especially in large nodules, and that nodules that are close to important structures. You have to continue observing this patient with ultrasound periodically, and you have the issue of the cost that varies from one country to another. It varies about the social security of the insurance of the patient. You need to take this into account too. Well, comparing radiofrequency with microwave ablation, I understand you have initial experience with radiofrequency ablation. I will show you later some papers about this, but just to state some differences. The heating speed. Microwave ablation transfers the heat much more faster than radiofrequency. It's a most efficient mechanism of energy delivery to the tissue. Then we can achieve the same results of radiofrequency with less energy and less time of the procedure. The sensitivity to tissue properties. Microwave penetrates and hits any type of tissue. As soon as the tissue has water, microwave will penetrate the tissue. But radiofrequency is limited by the tissue impedance. What's the tissue impedance? It's the resistance to the passage of the electric current after some points of coagulation, necrosis, and desiccation of the tissue. The radiofrequency does not continue to ablate in a tissue that's previously ablated or coagulated. But microwave, if there is any quantity of water, it will penetrate and hit the tissue continuously. But we can see that the impedance is a marker of efficacy. The devices of radiofrequency gives us the feedback of the impedance of the tissue. Then you can move your electrode to another zone and make sure that the previous zone are correctly ablated. You do not have this kind of feedback from microwave devices. But even is being a marker of efficacy, it's been a limitation of the technique of radiofrequency that you can always take into account. The energy containment. The microwave antennas disperses energy very near of the tip, less than 2 centimeters radius. And in the radiofrequency, the energy flows through the patient's body, and you need to put dispersion plates in the patient. And for example, in patients with pacemakers, you cannot or should not use radio frequency, but you can use without any concerns the microwave device. The heat sink effect or the losing of the heat, it's lower in microwave ablation, mainly with the current system that have refrigeration. The antennas are cooled with cooled saline. The first antennas 10 years, 12 years ago were not cooled. That causes much more heat sink effect. And it has much lower sensitivity to blood vessels and blood perfusion. For example, if you have a tissue with a high blood perfusion, for example, an autonomous nodule, or a large nodule with blood vessels inside it, radio frequency will lose much more faster heat than microwave ablation. Then this is another advantage of the technique. And here we have this graphic showing the performance of microwave ablation compared with radio frequency. For example, for depths of 5 millimeters and 15 millimeters, the generation of heat is much more quick and much more efficient in microwave than in radio frequency devices for the same time and for the same depths of the structures. But if microwave have these advantages, why RFA is most commonly used? We have very reasons. The RFA technology is much more older. It's being used for at least 20 years in thyroid nodules, for example. Microwave is latest. The first antennas of microwave are uncooled antennas, leading to some problems. In the first devices, the control of the ablation halo and the intrinsic generation in radiation was not so good. The distribution of conventional microwave probes, the first ones, was very high. It was very difficult to control. As I said before, whenever there is water molecules, the microwaves will excite the dipoles and deliver energy. And nowadays, with the newer tips, the newer antennas, we have much more better control of this halo ablation. And the problems are just this. We have a single size of active edge. We could have more size of active edges for example, larger nodules. The control of ablation are given only by the time and power relation and the hyperechogenicity in the ultrasound. But the earlier hyperechogenicity generated by the microwave could be a problem in the initial cases. Just for this, you have to be much more careful in your initial cases. You should start with not so large and not so small nodules. Nodules with 20, 15 mLs or cc's are the best ones to start, and nodules that are not in proximity of dangerous space or important structures such as the recurrent laryngeal nerve, because the halo of ablation is more powerful than in the radio frequency, for example. And there is a non-metallic window in the tip of the antenna that serves to control the emission of the energy that leads to a great fragility. The antennas of the microwave device are not very sharp, and you cannot try to break through the skin only with the antenna. If you do this, you can break the antenna in patients with harder skins, in harder fascial layers, for example. And the best way is to use a scalpel, a fine scalpel, to punctuate the skin and the fascia, and then introduce the antenna without problems of breaking the antenna or making some damage to the patient's neck, applying so much strength. Well, Let's see some of the literature we have available. I have a lot of articles to share with you. If you want, you can contact me. You have my email, my phone. We can share information, experiences. But I will show you some of the largest casuistics we have, comparing these two techniques and some articles about microwave only to show some specific topics. For example, in this publication with a large number of patients, 49 patients in RFA group and more than 600 patients in the microwave group with similar characteristics. The results shows us that the real value of reduction of the nodules are slightly higher in radiofrequency group with slightly lesser complications, but we can explain this why. Because in the first cases of the microwave group, these cases were performed with uncooled antennas, leading to more heat delivery around the tipped antenna and the shaft of the antenna, and some complications that are not so important, and most of them are reversible complications. This study with 60 patients with 65 nodules, 36 patients treated with radiofrequency and 24 with microwave, using a technique that is a node technique. It's a multiple overlap shotting, in contrast with the moving shotting technique we use nowadays, with nodules with similar volume, similar energy delivered, with a little lesser time of ablation for microwave. And the number of shots of microwave are lower than the radiofrequency ones, and the shrinkage of the nodules is about 43% in 3 months and 51% for RFA in 3 months. This is important to note that we can expect the most of the shrinkage of the nodes between the 3rd and the 6th month. If you achieve the 6th month of follow-up of this patient, and you have no more than 50% of reduction of the nodule, maybe you can apply it something wrong technique, or maybe you cannot have applied the hits to all regions of the nodule. Complications are very low. One case of temporary Horner's syndrome, a larger node, and heat sensation, but we can state that in these cases, some of them are performed with non-cooled antennas, and the results are very similar for both techniques. This meta-analysis that includes these 5 papers with this number of patients, more than 800 for microwave and almost 900 for RFA, shows us the reduction rates in 3, 6, and 12 months, showing the reduction rate, the real reduction volume rate of 86% for microwave and 80% for radiofrequency, with no difference in complications, showing that techniques are very similar, and each one has its own advantage and its cons. Well, for nodules over than 3 centimeters, we have the results of this study. The larger nodule in this study was 6.5 centimeters, and the minor one is 3 centimeters. Most of them are in spongiform or partially cystic, and most of them 70% they perform it in a single section, with a time from the first to the second ablation varying from 2 to 15 months. These are the results. This is the curve of volume reduction ratio for these cases, with the symptomatic score decreasing radically and achieving a 96.4% of real volume reduction rate in 12 months, showing that this technique is very, very efficient, even for larger nodules. In this table, you can see the differences about the echogenicity of the nodules and the solidity of the nodules, showing that nodules with mainly cystic or mixed characteristics are more suitable to greater reduction during the time. Well, this other paper comparing the different internal characteristics of the nodules with this number of patients. Most of these nodules are solids or mainly cystic, and here is the importance showing in this table that the morphological characteristics of the nodules seems to influence the reduction. For example, here in nodules mainly cystic or not only solid nodules, we have much more reduction rate than in the simple solid nodules. Then the mainly cystic and the mixed nodules are the best ones to expect a better reduction rate after ablation with microwave. This is a very interesting study. I had only one intercurrence that are cited by these authors in my casuistic. They treated, 89 mostly cystic nodules in 59 patients with microwave. In 10% of these patients, they had intracystic hemorrhage during the procedure. And they showed that the bigger nodules are the most likely to be bleed, and this hemorrhage enlarged the duration of the procedures, worsened the outcome of the patient, and they discussed how to prevent and manage the complications. And here are the image of a mainly cystic nodule, a very tense nodule, and this kind of nodule you have to take very to be very careful and take some precautions, because these nodules with these vessels in the edge of the nodule are more prone to bleed during the procedure when you start to apply the energy and to evaporate the liquids. And here we can see in this image the bleeding inside the nodule. In some cases, these authors need to convert to an open surgery because the bleeding was very high. And the risk factors for this occurrence are nodules that are larger than 3.5 centimeters. And what can we do if it happens? First, stop the procedure and put local compression during 3 to 5 minutes and see with the ultrasound if the hemorrhage stops. If the hemorrhage stops, you can aspirate the blood and restart ablation. But if the hemorrhage remains, you can try to place the antenna and aspirate simultaneously with ultrasound guided vision and apply the ablation over the point of bleeding. It is a very difficult technique to be done, and you have to be sure that your skills are good for this. And you have to pay attention during the ablation for the points, possible bleed points near the capsule, because these enhances the hospital stay, this enhances the operation time, and it worsens the results. For example, in the bleeding group, after 12 months, after 1 year, they have only 56% of reduction, comparing with 83% of the control group that are the patients that have no bleeding. Then, this is one important key to be observed when you try to treat mainly cystic nodules with microwave. Well, let's talk something about the technique. First of all, you need to remember the anatomic landmarks. You need to be skilled in ultrasound of the thyroid gland. Remember the trachea, the tracheoesophageal groove, the internal the carotid artery, the jugular vein, the vagus nerve, and the skin of the patient over the muscles. We have a danger zone here between the medial border of the thyroid gland and the trachea, where the recurrent laryngeal nerve lies, and you need to avoid this area, to avoid the proximity of the tip of the antenna of this area. And if you have a very large nodule that encompasses this area, you can choose to do not perform the ablation near here. In the first cases, the recommendation is to ablate about 80% of the nodule. You don't need to worry if you leave about 20% here, for example, for a second time, or in most cases, most of the nodule will shrink and the patient will be happy, and you have a very good reduction of the nodule without symptoms, without complications. First of all, be careful. Well, the technique starts like we see here, with the patient in supine position. You can mark in the skin of the patient the nodule and the direction of your ablation to plan this before. In every case, you need to register the diameters of the nodule, the volume of the nodule, and with the Doppler mode to register the density of vessels inside and in the capsule of the nodule to make comparisons with the postoperative ultrasounds. We start with anesthesia under the strap muscles and the thyroid gland, and this is one important tip. You can put your needle until you almost reach the capsule of the thyroid, and then retract the needle to avoid inject the anesthesia, the anesthetic solution, inside the fascia, and do not have the effect to anesthetize the thyroid capsule, as you can see here. The injection of the anesthetic here. Well, we can see here that this target nodule is very close to the trachea. When you have a nodule very close to an important structure, you can choose to hydrodissect this area. You can use saline, you can use glucose 5% or dextrosis. In some countries like ours here, it's much more difficult to find dextrosis, and we use 5% glucose. And here is the needle between the trachea and the thyroid, creating with the solution and space to ensure safety of the procedure. We are putting the thyroid away from the trachea to perform the ablation of the nodule here. And this is the technique of hydrodissection that can be used in this area between trachea and thyroid, that can be used in this area between the carotid and the thyroid, and so on. And here is the antenna ablating the nodule with safety, because of this zone was created between the structure, in this case the trachea, and the thyroid. The technique is the same used in radio frequency, the transrhythmic approach, but we have to note that with microwave antennas, you cannot follow all the time this transrhythmic approach. We can approach from other sides because it's safe, because it's not hits in the shaft of the antenna, and you cannot cause lesions in skin of the patient, for example. The technique as described by Bayek for radio frequency, starting with the more medial and lower zones, thinking about the thyroid nodule as an elliptical structure. You can divide this in very many slices, starting from the bottom to the top of the thyroid, progressively ablating all the areas of each slice. Remember the danger zones, the zone of the recurrent laryngeal nerve between the thyroid and the trachea, the vagus nerve between the jugular vein and the carotid, and more rarely, but it can be it can occur, lesions of the sympathetic ganglion causing Horner syndrome. You have to pay attention for these two. Another tip is when you have a mixed nodule, for example, like this one, you can aspirate the cystic part, as you can see here, and then ablate the solid part of the nodule to improve better results. This is a very interesting case. This is a young lady, 25 years old, with a 4-centimeter thyroid node, with a zone in this node near the trachea. And we have no, because of the anatomic of the neck of the patient, we have no space and no angle to put the antenna to ablate this zone here, and neither to hydrodissect this area. And then we start ablating the areas far from this zone, as we can see here. And then after we have ablated all the node where we can, we need to do, we reached this area close the trachea through the right, to the side of the neck, not from the middle, like here. We can put the antenna from the side of the neck to put the tip near, but not so close of the trachea, preserving this dangerous zone, and to ablate this area that could not be reached from here, for example. It's another advantage of microwave ablation. After the procedure, or during the procedure, you can check your progress. For example, you can see here scan in the longitudinal way of the nodule. And here we can see a technical error that can be done in the first cases. Here, the operator ablated only the medial third of the gland of the nodule, not the lower, not the upper zone. This is a not good result, because if you put your ultrasound probe in an axial way, it will be very difficult, due to the hyperechogenicity created here, to see clearly the inferior part of the nodule. Then always start with the inferior parts and then go to the superior parts to avoid this kind of results. And then when you complete the ablation, you can scan all the nodule to see if you ablate all the areas, as you can see here, from up to down. And this is the aspect of the thyroid completely ablated after a single session. Another thing you can do with the ultrasound is to check the vocal cord mobility. Here we can see both vocal cords with the ultrasound during the procedure. If you have any doubts, if you put your antenna close to the nerve, if the patient changes his voice. For example, in this case, we can see clearly the vocal cord palsy in this side, comparing with this one. If you have this kind of events, if the patient changes his voice, that's why it's important to maintain a mild sedation, not a deep sedation, to speak with the patient all the time. If you have this kind of occurrence, you immediately put 10 cc's of saline, isosaline or glucose 5% in the region of the nerve, and waits for the patient to enhance the voice and to start moving the vocal cord again, and then you proceed with the ablation. Here I can see, I'd like to show you our first case. This case was performed in the last December. This was the first that we performed with microwave. It's a 60-year-old patient with a large nodule, a mixed nodule, with a volume of 42 cubic centimeters. We performed the ablation in about 12 minutes with 40 watts of power. And this patient delayed his first ultrasound because of COVID. Our protocol includes an ultrasound 1 month and 3 months, 6 months, and 1 year after procedure. But 45 days after the procedure, the nodule was reduced in 2/3 to 15 cubic centimeters. And 3 months after, the nodule had reduced 83.3%. I haven't put here because I performed yesterday the last ultrasound of the 6th month of the patient, and the nodule has lesser than 2 cubic centimeters, showing a very, very good response. The patient's happy, we are happy too. You can see anything in his neck, and the thyroid function is preserved. This is the second one. It's a lady with 72 years old with some problems, cardiac problems that could lead her to complications during a traditional surgery. It's a 23 cubic centimeters volume nodule. This is the measures. We can divide the screen to show all the nodule here. And after 45 days of ablation, we have a reduction of 70% of the nodule. It's a very, very good reduction rate. With the patient without symptoms, the nodule is barely visible, only palpable. And this is the results we can achieve, we can see in our patients. And this is the great goodness we can do for our patients with this technique, with no scars, with no general anesthesia, and the main important, do not leading to hypothyroidism like in the traditional technique of thyroidectomy. Thank you very much for your attention. Here is my email, here is my Instagram. You can contact me anywhere. Thank you very much.